Welcome back, medical detectives. Let's jump right into today's explainer, where we're going to master extracting accurate, billable codes from complex surgical reports. We're breaking down exactly how you prove medical necessity for surgical procedures, the absolute critical differences between endoscopic and open approaches, and those essential billing rules you absolutely need to know. Let's get to it. Start with proving medical necessity, move through arthroscopy and scope families, laparoscopy, open surgical procedures, verifying documentation, and finally, bundling and billing rules. Section 1. Proving medical necessity. Now, here's a massive rule you've got to remember. You can only code based on the post-operative diagnosis. Why? Because a preoperative diagnosis is essentially just an educated guess based on initial tests. But for billing, you need the absolute final truth. And that postoperative finding, which is confirmed by the surgeon actually looking inside the bodily cavity, is absolutely required. Which brings us to your core obligation as a coder, ensuring the diagnosis in the chart is totally compatible with the procedure being billed. You should never, ever speculate or invent a diagnosis based on what you think the doctor meant. If the chart doesn't accurately portray the method, stop right there. You have to ask for clarification. Section 2. Arthroscopy and scope families. Let's break down the terminology. The suffix scopy literally means the employment of an instrument to see. It's pretty incredible. Orthopedic doctors create these tiny incisions called portals. One portal is for visibility, and the other is for slipping in incredibly small tools. They inflate the joint with fluid, and suddenly, the surgeon can inspect the entire interior of a knee or shoulder right on a monitor. Now, a crucial point here is that arthroscopic treatments are grouped into what we call scope families. These are operations routinely performed together. Take a normal arthroscopic knee operation, for example. The surgeon intrinsically inspects all three of these compartments, the medial, the lateral, and the patellofemoral. Since this routine inspection doesn't require any extra effort, it's completely bundled in. You can't bill it separately. But if you want to get paid for extra work, like a chondroplasty, the doctor's paperwork has to detail exactly what was accomplished compartment by compartment. The AMA and AAOS set incredibly strict parameters for what can and can't be billed individually here. If that compartment-specific documentation is missing, you simply cannot prove the extra labor was performed, which means no extra reimbursement.
Section 3. Laparoscopy, also known as Band-Aid surgery.
They call it Band-Aid surgery because those tiny incisions usually just need, well, a simple bandage. Here, the surgeon utilizes a scope in the abdominal or pelvic cavity. But to create enough space to see and operate safely, they actually have to inflate the patient's belly with gas. It's a key hallmark of this specific endoscopic approach. And that perfectly sets up a major rule for these scope families. Let's say the surgeon goes in with a scope just to take a look. That's a diagnostic laparoscopy. But while they're in there, they find a wildly inflamed appendix and remove it. Guess what? You can only bill for the surgical appendectomy. The diagnostic part gets completely swallowed up and bundled into the surgical part. Oh, and if they spot a contraindication, like severe inflammation, they have to abort the procedure immediately for the patient's safety. Section 4. Open surgical procedures. Sometimes those minimally invasive methods just aren't enough, and doctors have to pivot to a traditional open procedure with a larger incision. Here is a massive rule you need to lock in. If a doctor starts endoscopically, but runs into trouble and has to make a traditional incision to finish the job safely, you only code the open procedure. When you're abstracting these complex open surgical reports, you're essentially playing detective. You have to navigate through distinct sections to find your proof. There's the heading, your pre- and postoperative diagnoses, a quick synopsis, and finally the comprehensive body of the report. That's where the actual evidence lives. So whatever you do, never code from the header or the synopsis. Think of them as just teasers. The absolute golden rule is that the actual proof of the procedure must be detailed in the comprehensive body of the report. If a doctor casually lists a procedure in the heading, but completely forgets to describe it in the main narrative, from a billing perspective, it literally did not happen. Section 5. Verifying surgical documentation. So what happens when you run into a gap in the documentation? You definitely can't just guess. You have to initiate a physician query. But you have to be extremely careful not to lead the physician or put words in their mouth. That is a huge compliance risk.
You simply ask non-leading questions for clarification, and then the surgeon dictates an addendum or corrected note. Only when the medical record is officially updated can you actually bill it.
And finally, Section 6, Bundling and Billing Rules. You really have to keep a sharp eye on incidental procedures. These are ancillary operations that are just a necessary part of the main surgery. For instance, creating an incision to start an open surgery and then stitching it up at the end. Totally incidental. You cannot unbundle that for extra cash unless the surgeon meticulously documents that significant, extensive, extra labor was required, like complex tissue rearrangement. But while we absolutely must avoid improper unbundling, we do have specific modifiers to tell payers the full story when things get complicated. The key ones you need in your toolkit are Modifier 25, which you use for a significant, separately identifiable evaluation and management service on the same day. Then there's Modifier 51 for multiple procedures during the same session. And of course, Modifier 59, which flags a distinct procedural service that completely justifies separate billing, despite standard bundling edits.
Look, avoiding errors like incorrect unbundling, billing for more than what's actually documented, or just ignoring those glaring documentation gaps is exactly how we maintain compliance and earn respect in this industry. True coders follow the guidelines meticulously because we have access to highly sensitive information and our work directly impacts the financial stability of the entire practice.
By deeply understanding medical necessity, knowing the crucial differences between an arthroscopy and an open procedure, and mastering the strict rules around those modifiers, you are now fully equipped to tackle the absolute toughest operative reports out there.
So, the next time you look at a complex surgical report, ask yourself, is the evidence truly in the narrative, or is it just an educated guess? Please like, share, and subscribe to Decode Healthcare with Harshal.